they pulled me aside and wrapped a blanket around me and made sure I was okay.
All right, can everybody out there hear me? Give me a thumbs up if you can hear me. Perfect. Okay, it's Josh Freeman. I'm with the Genesee County Board of Commissioners office. I've got Marie Clifford here with us, who a lot of you have probably emailed with or talked to over the last few days. And then we've also got Anita Galita from our HR department. She's our director. And then Star Lucas, who is moderating for us on the Zoom meeting. I just want to mention a couple of things before we get going. Plant Moran, Jonathan will actually be doing the presentation on behalf of the county. He and his team will be able to answer questions for you after the presentation is over. So all of the handouts that we will be seeing today will be located on the special VIBA page that the Board of Commissioners have on the website, as well as a video recording of this session. And it looks like Carolyn is trying to share her screen. And I think we're going to kick you off of that, Carolyn, as we move through this. As they're trying to work through that, you'll notice a couple of things. So if you're on a telephone call only, you will, in order to raise your hand and get in the queue for the questions at the end, you're going to want to hit *9. That'll put you in the queue to ask the questions at the end of the meeting. And then if you are on the actual Zooms, Are you able to? Okay, there you go. If you're on the actual Zoom meeting, at the bottom of your screen, there's a participants button. If you click on that button, there'll be a white screen on the right, and on the bottom of that white screen, there is a raise your hand button, and that's how we're going to work through the process of asking questions during or after the presentation is done. So with that, our last two sessions have lasted about 2 hours. That's what we're going to allot for today. So at 4 o'clock, we'll try to wrap it up. I am always available, or HR is always available to answer any questions that maybe come up a little bit after the presentation. My direct dial number in my office is 810-762-7762. It's a full house if you're a card player. And then the email that you can use is VEBA, V-E-B-A, @co.genesee.mi.us. And I'll put those in the comments at the bottom for everybody so that you can see that in the chat comments before we're done. So without further delay, Jonathan, if you want to go ahead and take over, and we can get the presentation moving, and then we'll get to the questions that anybody might have.
All right. Thanks, Josh. Welcome, everybody. Good afternoon. Good morning if you're out on the West Coast. Today we are going to go over a review of the benefit changes for county retirees. I want to just lay out a little bit of groundwork first. In terms of introducing myself, my name is Jonathan Trianfi. I'm with Plant Moran in our group benefit advisors practice. I have a few folks on the phone with me today, Claudia Hermes, Jordan Richard, and Ed Murphy. If you're using the chat feature in the Zoom meeting to ask questions or write comments, you might see one of them respond with an answer or another comment to address the discussion that's going on. So if you see those names, they are part of the team here at Plant Moran. Also, this presentation is really going to be broken into two parts. So the first part is going to be exclusively for pre-Medicare retirees. So those of you that have not hit Medicare age yet or become eligible due to a disability or anything like that. So if you're not on Medicare, the first part of the presentation is going to be for you. The second part of the presentation is going to be specific to Medicare retirees. So if you are enrolled in Medicare, that's the section of the presentation that will be pertinent to you. And without further ado, I'm going to dive right in. So again, this first section is for those retirees that have not reached Medicare yet. So what are we going to go over as part of this presentation? We'll take you through a quick overview of how things exist right now. We'll take you through a summary, kind of summarize what's changing, and then we'll get into a little bit more detail. We'll go through the different components of the benefits and how they'll work, the value add or benefit add services that we'll be rolling out, and then we'll talk through how the plan designs work. So first and foremost, if as a county retiree, you are likely receiving benefits in one of a few different ways. Some of you may currently have coverage through Health Alliance Plan, and that coverage might be delivered through a PPO or an HMO. Some of you also may have coverage through Blue Cross Blue Shield of Michigan. And again, some of you may be enrolled in a PPO with Blue Cross of Michigan. Some of you may be enrolled in what's called a comprehensive major medical plan. All of you should be receiving prescription drug benefits through Express Scripts. So you should have an Express Scripts card, and that's the card you will likely be handing to the pharmacy when you are picking up your prescriptions. So regardless of where you're getting your medical insurance, you should be getting your prescription drug benefits through Express Scripts. So to summarize what's changing, effective January 1st, 2021, all pre-Medicare or pre-65 retirees are going to shift from their current arrangements with Health Alliance Plan or Blue Cross Blue Shield of Michigan to Meritain. So Meritain is going to be the new plan administrator. Okay. Now, Meritain is going to be the plan administrator. They are not a network. They're not an insurance company. Okay. They're just the ones that are administering the plan. The network of doctors and hospitals that we'll be using is the Aetna Choice POS2 network. That is a national PPO network. So it has doctors and hospitals coast to coast. And it has, frankly, it has a very extensive network in Michigan. So if you are still residing in Michigan, it has that network, that Aetna Choice POS2 network, has all of the hospitals in Michigan. It has about a 98% overlap with doctors in the state of Michigan. The other thing I want to point out too is that, and reiterate, is that that network travels with you. So even if you reside in Arizona, but you spend, or if you reside in Michigan, but you spend 5 months of the year in Arizona, that network is going to go with you to Arizona. You don't have to change anything. There will be providers, hospitals, doctors in Arizona, just like there are in Michigan. The other thing is that, and you'll hear reiterated during the presentation today, but we try to keep plan design changes minimal. Okay. The county, the commissioners, we all understand that your benefits are very important to you. That, in prior conversations that has come through loud and clear from the retirees, and we understand that. So we try to keep these plan design changes as minimal as possible. The last thing is that the prescription drug arrangement right now that you have with Express Scripts is going to remain. Okay? So we are not changing the Express Scripts relationship. There will be some changes, as there always are in the prescription drug world. Every 6 months or thereabouts, drug formularies get updated. So that drug formulary will be updated on January 1st. The county is also going to be rolling out a new program. It's not likely to hit a lot of people, but those of you that are taking a specialty medication, and if you're not quite sure if you're taking a specialty medication, you're likely not taking one. They're very, very expensive medications, sometimes upwards of $8,000–$10,000 a month. We are rolling out a new program that will allow the county to source those medications on your behalf at a lower cost. And by doing so, we're also able to dispense those medications through the benefit program at zero copay. So those few of you that are taking these medications will be, we'll see a small benefit in the form of a reduced copayment or elimination of a copayment on your specialty medications. The other thing that you're going to see, which is going to be I would say a bigger change, and this is more of a mindset change or an approach change than anything else. We are going to be rolling out a number of new services that are meant to help you navigate the healthcare system more easily. So the first is Quantum Health, and we'll get into more detail on all of these later in the presentation. But Quantum Health is going to be an advocacy program that's going to be your first point of contact. If you're a pre-Medicare retiree and you have questions on your benefits, Quantum Health is going to become your first point of contact. Okay? And we'll explain why in a bit. Also, I mentioned earlier that you're likely carrying around a Blue Cross or a Health Alliance Plan card for your medical and a prescription drug card from Express Scripts for your prescriptions. As of January 1st, you will have a single ID card. Okay. So your prescriptions and your medical will be on one ID card. We're also going to be rolling out or actually expanding the Livongo relationship. So some of you may be familiar with this service right now, but Livongo is a program to help diabetics manage their condition. Again, we'll talk a little bit more about that in a bit. And the last thing is a service called the KISS card or KISS-X. And this is a program. It's completely voluntary, but it's a program that allows you to have an opportunity to waive your deductible, waive any copays or co-insurance associated with schedulable surgeries and other complex medical procedures. So this is a program, if you work with the folks from KISS, you'll be able to get knee surgeries or MRIs or things like that done, and all of your out-of-pocket costs will be waived. So with that, we're going to get into a little bit more detail. So the first things first, most people, whenever they hear about a benefit change, the first thing they get concerned about is my doctor, or is there a hospital that I can go to that's in the network that's close to my house? Okay. First of all, like I mentioned before, the Aetna Choice POS2 network, it's an open access PPO that has providers, hospitals, doctors, coast to coast. Okay. Like I mentioned earlier, in the state of Michigan, the network includes every hospital in the state and about 98% overlap on doctors. So can I guarantee that every one of your doctors for every single person on the phone is in the network? I can't guarantee that. I can tell you that there'll be few and far between the doctors that are not in the network. If you are concerned or want to look up your doctors right now, you can do that. My recommendation is that you use the Aetna website. So that's www.aetna.com. You will see a button on the page that says find a doctor. If you go ahead and click that and then choose that you're going to be looking for doctors via a plan from your employer. And then you're going to go through the search process as a guest. Okay, so it'll ask you, do you want to log in or do you want to search as a guest? You're going to want to search as a guest because your benefits with them aren't actually live yet. Okay. From there, it's going to ask you about like what type of doctor you're looking for or what type of hospital, where you're geographically located. So are you looking in Michigan or are you looking in Arizona or Florida? So it's going to ask you to do that type of search. But that is a search that you can do right now. The other thing to note, though, is you're going to want to remember the name of that network, the Aetna Choice POS2 network. My recommendation, as Josh mentioned earlier, if you're going to do that search, go out to the county's website, grab this presentation, pull it up so that you can remember how to do the search properly. All right, so plan designs. So I mentioned earlier that the plan designs will be changing. Most of you will be experiencing a small change to your plan. Okay. The changes in the plan are meant to be limited to 1 to 3% of an actuarial value change. I want to be clear on what that means. 1 to 3% does not mean each of you individually will only pay 1 to 3% more. 1 to 3% actuarial value means on average, the overall value of the plan is only changing 1 to 3%. And the reason I want to point that out is insurance is it's in general pooled product. It's just like it's just like any other insurance, life insurance or car insurance. Just because you're paying into it doesn't mean you're always taking out of it what you're paying into it. Okay. So when we say 1 to 3%, we're not talking about each one of you individually only paying 1% more than you're paying right now or 3% more. Okay. The other thing is that each one of you that currently are a pre-Medicare retiree, you're going to be moved into one of 3 Meritain plans. And you're going to be moved into one of the 3 plans based on which plan come January 1st is closest in value to the plan that you have right now. So you'll see that these 3 medical plans, and we'll talk about them in a bit, these 3 medical plans, they have 1 of 2 levels of prescription copays. One of the plans has prescription drug copays that are $2 for generics, $5 for preferred brands and $5 for non-preferred brands. The other two Meritain plans both have a prescription drug benefit that has $5 copays for generics, 20 for preferred brands, and 40 for non-preferred brands. So if we kind of take a step back, talk about how people are going to be placed into the benefits. For example, if you're on a Blue Cross plan right now and your prescription drug copays are $2, you're likely moving to the one of the Meritain plan that has $2 generics and $5 brands. Okay, so that's how that mapping is going to work. You're going to be moved to the plan that has the closest value to what you have right now. And we'll talk more in detail about the plans in a bit. Now, you're going to hear me talk about this twice, both in this part of the presentation and again later in the second part of the presentation. In the event that you are covering more than yourself and you have a family member that's Medicare eligible and you have a covered family member that's not Medicare eligible, those situations are called a split contract. In the case of a split contract, the family member or members that are pre-Medicare will receive the benefits that we're going over right now. The family member or members that are post-Medicare will receive the benefits that we'll talk about in the second part of this presentation. So there will be situations where a family unit, part of the family unit will have one set of benefits and the other part of the family unit will have another set of benefits. So now we're going to talk a little bit about what we're considering a point solution or value add to the benefits that's being rolled out as part of this change. So the term point solution, really it's just a fancy term for different things that we're including in your benefits that are meant to help you or provide extra value or options to you in your benefit plan. And over the next couple pages, we're going to talk about what those value adds are, those point solutions. So first and foremost, quantum. I always tell folks that if you're anything like me, first time you hear something, you're probably only retaining about 15 to 20% of what you're hearing. So if there's one thing that I want to make sure that fits into that 15 to 20% today, is you remember the name quantum. Okay. The reason for that is if you forget everything else, if you just remember quantum and you remember to call quantum, they're going to be able to help you with pretty much any other question that you have. Okay, so what is quantum? So quantum, and you'll see it referred to in your benefits as MyQ Health. The Q stands for quantum. They are an advocacy service, but they're also doing medical management and care coordination. So these are some things that traditionally most people don't even know is happening behind the scenes, and it's because it's happening between doctor and insurance company, and a lot of times the patient is not included in this process. The quantum solution is meant to engage you as the patient so that you can be a more informed consumer of healthcare. Frankly, so that you have somebody acting on your behalf while you're navigating what is a very, very complex healthcare system. So I'll give you an example. How many of you would feel comfortable identifying which surgeons in your general area have the highest or best outcomes on the type of surgery that you're receiving? A lot of times you refer to, friends or family for referrals. But the folks at Quantum actually have real metrics, statistical metrics on outcomes for surgeries and things like that. And they can actually help you, if you're interested, they can help you identify who those best surgeons are. So if you're PCP, I'll use an example. If you are seeing a primary care physician at Henry Ford Hospital, it's very likely that that primary care physician, if you needed surgery, is going to refer you to a surgeon in the Henry Ford hospital system. Well, the surgery you might need in your general area, maybe the best surgeon in the area for that procedure is at Providence or Beaumont. Again, that would be good information to have. You can choose to use it or not, but it's good information to have. The other thing is that Quantum can actually reach out to you prior to services being provided to make sure that you are comfortable with the service that you're about to have. They can ask you the questions that you might be uncomfortable asking to your doctor. They can have some of those conversations on your behalf with the doctor if you don't feel comfortable having them yourself. So again, these folks are really meant to be your advocates in the healthcare system, and they're they're really there to help you be better consumers of healthcare. Now, you might say, well, who are these Quantum people? Like, what are they credentialed to do this? Are they not? The folks at Quantum are made up of both customer service individuals, but they're also on each team. They have clinicians, nurses, nurse practitioners that can actually work on your behalf and talk to you about the clinical nature of what you're dealing with. So it's not just they're not just customer service people. There are clinicians at Quantum that can help you. They have PharmDs, so if you've got prescription questions, they can help you with that as well. So what else can Quantum do for you? This page right here is really meant just as a summary of some of those things. They can help you with basic questions like verifying your coverage. They can answer questions about claims or billing. So if you get a bill from one of your docs and you're not quite sure if it's appropriate, you can call them and they can work through it with you and determine whether or not that bill is appropriate. Their clinicians can also help you develop health improvement plans. So if part of your follow-up care, for any type of medical procedure didn't include like health improvement or, diets, things like that, they can work with you on that. Like I said, they're also going to be working behind the scenes with your docs. So they're going to be making sure that, the things that are being, the services that are being provided are clinically appropriate. So while it doesn't happen a lot, there are times in this world where a doctor might suggest to you that you need to have a surgery, when in fact the proper course of treatment might be physical therapy. Okay. So that Quantum is also going to be looking at that type of stuff to make sure that, again, you're best taken care of. And last but not least, what they can do is, as we go through the rest of these different solutions, these point solutions, they can remind you that they're available to you. So that's what I said before. If there's one thing that you should take away, if you don't remember what we talk about today, the one thing to remember is call Quantum. All right, so the next solution. The next solution is a program called KISS-X, or the KISS card. This is a voluntary program, so let me reiterate that this is not something you have to use. It's just an option. Okay. And the reason this option exists is we wanted to provide people an opportunity that if you engage with the folks from KISS and the folks from Quantum, they're going to be able to help you identify places that you can have schedulable surgeries, imaging, certain high expense lab work. If you work with the folks from KISS, they're going to work to find you a provider that will provide that service, and all of your out-of-pocket costs will be waived. Now, you might say, that doesn't sound like something I want to do, or how are you doing that? Well, this kind of works like travel sites. Okay. The healthcare industry, there's a lot of similarities with the hospital or the hotel industry. If there is an OR that's unoccupied, Hospitals a lot of times will negotiate a specific price just for your surgery because they don't want that OR to be empty. Okay? It's just a business thing for the hospital or for the facility. So what KISS does is they'll work to find that opportunity, and they will then bundle all the services associated with that procedure. So like if you have a knee replacement, KISS will actually negotiate with the facility, but as part of that negotiation, they will also include your anesthesiologist. They will include the surgeon's fee. They will include the facility fee or the operating room fee. So all the things that you might otherwise pay for separately, all those things will be bundled together, and you will pay nothing for the service. Now, if you're concerned about quality, I can tell you this as well. There is typically an inverse relationship between cost and quality in the healthcare space. Think about it this way. A surgeon that takes 6 hours to perform a surgery, they need to occupy the operating room for 6 hours. If a different surgeon can perform the same quality surgery, possibly better, but can do it in 2 hours because they're better at the surgery and they have more experience doing it, then they need to be in the OR for a shorter period of time. So in effect, the surgery actually costs less. Okay. So that's how this program works. Again, it's voluntary, and it's not going to include every service. It's only going to include the services that are schedulable. So if you need to have an emergency appendectomy, this isn't the program for you. You need to go to the hospital and get that taken care of because it's likely an emergency. This program is specifically for things that you can schedule. All right, so this next page is just a quick look at where some of the provider locations are. Again, we know people are scattered around the country as retirees. You may not be living in the Michigan area anymore. That's okay. Really, the point is we're trying to demonstrate that there are providers in the state of Michigan, but there are also providers all over the country. The other thing to keep in mind is that this program is not like a PPO or an HMO where you can just go look up a doctor. A lot of times the folks from KISS are creating an arrangement specific for you with a specific provider. So it's not something you can go out and look up on a website. In order to take advantage of this, you have to engage. If you want to initiate the process through Quantum, they can get you looped in with KISS, or you could call KISS directly if you want. Okay. All right, the next program is a virtual primary care program through a company called 98.6. This program is for virtual consults. So some of you may be more familiar with this concept after the last handful of months of what we're all dealing with in terms of COVID and having care delivered virtually or talking to your doctor over the phone as opposed to seeing him or her in the office. That's what this program is. This program is for virtual consults. So you can initiate a consultation either through a smartphone app or through the website, their website. And if you want to consult a doctor through this program, there is no copay or no out-of-pocket cost to do so. Those consults are completely covered. You do not pay a thing. The process is very interesting. So you would actually initiate your consults and do all of the intake via text messaging. So where if you've been to a new doctor recently and you have to fill out some questions, a lot of that intake is going to be done via actually an artificial intelligence intake system that will then give all that information to the doctor when they jump on the line with you. So eventually the doctor will come on, you will consult directly with the doctor. Either you can continue the process through text messaging, or they can initiate a phone call or a video conference with you. The other thing to note here is that in this program, all the doctors that you'll be working with or consulting with are employed by 98.6. So they're not just 98.6 isn't just connecting you with some random doctor, you know, and we don't know that doctor. All of the doctors that you're going to be dealing with are employed by 98.6. The last thing I would say on this, in terms of how it should be used, it's really a complement to primary care. It's not meant to replace your primary care doctor. It's meant to complement it. For those of you, if you have the same issues I do, you know, you want to go see your doctor for something that's not an emergency or not super urgent. Sometimes you have to wait 2 or 3 weeks to get in. If you've got a sinus infection, or you think you maybe got poison ivy or something, if you're out hiking, that's what this program is for. The doctors, if they need to, they can write you scripts. I've been telling the other groups that I've used this service before when I had a sinus infection. I get a sinus infection nearly every year at the same exact time when fall allergies kick in. I initiated a consult. From the point I initiated it to the point I was able to pick up my prescription from the Kroger up the street from my house was 90 minutes. So I had a doctor's office. I started a consultation. The doc wrote me a script as part of that consult, sent it over to the pharmacy, and I was in my car picking up that script, start to finish, 90 minutes. So this next page is just really meant to demonstrate how the program works. You would initiate the consult via text messaging. Like I said, the doctor will come on, you'll converse, you'll have your consultation. And then at the end of the consult, if there's a script that's written, that script will be sent to the pharmacy that you indicate. But the doc will also have a care plan written up for you, and it will be saved on your account with 98.6. That way, if you wanted to, you could print that out or download it and send it to your doctor, so your doctor can continue treatment if necessary. So the next program is Livongo. Livongo is a program for diabetics. This program, again, is voluntary. If you choose to enroll in it, what will happen is you will receive a smart glucose meter along with all of your testing supplies. All of those supplies will be sent to you at no cost, including the glucose monitor. Now, as you test each day, or based on how often you're supposed to test your glucose levels, you're going to use that smart meter. And in the event that you were ever to test out of range, out of an acceptable range, a clinician is actually going to be notified, and that clinician is going to reach out to you to help you get your glucose levels back in line. In the event that it is a serious issue where you might not be available because you might be dealing with a major medical event, those clinicians can actually reach out to emergency contacts on your behalf to make sure you're getting the help that you need. So again, it is a voluntary program. You don't have to participate. We think that this is one of those programs that if you are managing your diabetes, this can be a big help. And having the additional assistance and getting all of your supplies at no cost also isn't a bad thing. So this next page just gives you a quick rundown of how the program works. So you can see a small picture of the smart glucose meter there on the left. But I think the real value there is that data connectivity and the access to the clinicians that can help you in the event that you're dealing with a situation where your glucose is out of range. All right, those are the point solutions or the value add benefits that we're going to be rolling out with this change. The next thing that we wanted to go over was the plan designs. So we mentioned before, there are 3 plan designs. You will be mapped into one of the 3 plans. And what we want to do is quickly go over how these plans work. Some of you may not be as familiar with these plans. And again, change is, anytime there's change involved, and there's unfamiliarity. There's usually a reasonable fear involved with change. So what we want to do is try and minimize that so that you're comfortable and understand how these plans work. So let's talk about the first plan. This plan, for those of you, like I mentioned, that have $2 or $3 drug cards, this is the plan you're most likely going to be mapped into. Okay? And the way this plan works is there's in-network benefits and out-of-network benefits. Most often, you are going to stay in-network. Okay. By the way, if you happen to go to an out-of-network provider, the folks from Quantum are likely going to reach out to you and notify you that you're using an out-of-network physician, because sometimes the physicians won't tell you that you're out-of-network. Okay. So how does this plan work? First things first, the deductible. This plan has a $100 deductible per person with a family max of $200. So what does that mean? That means if you are covering, let's say you're covering a family of 5, each person in your family starts the year with a $100 deductible. But at no point in time will the family in aggregate ever pay more than $200 in total deductible expenses. So you can hit that $200 by 2 family members each paying their $100, or all 5 family members contributing $40 a piece, okay, in deductible expenses. But that family unit will never pay more than $200 total in deductibles. Likewise, if you have a family of 5 and only one person gets sick and has deductible related expenses, that one person is only responsible for $100 of the deductible. Now, after the deductible, after you satisfy the deductible, there's something that is called coinsurance that kicks in. Coinsurance is 10%. That means you're going to pay for 10% of the allowed amounts that are approved by the insurance company. Okay. So let's say you've satisfied your deductible for the year and you have a diagnostic test that costs $50. You're going to pay 10% of that $50 charge, just $5. Over the course of the year, no one person is ever going to have to pay more than $750 in coinsurance expenses in aggregate across the whole year. So this isn't $750 per event, it's $750 in aggregate over the course of a year. And just like the deductible, the family max is $1,500. So that can be met in a number of different ways, but if you're covering more than yourself, at no point in time across the entire family will you ever have to pay more than $1,500 in coinsurance expenses. Now, what you're going to see down this list here, you can see the types of services that are covered and what type of cost sharing applies. Any place where you see a copay, so things like office visits, physical or occupational or speech therapy, emergency rooms, urgent cares, chiropractic visits. There is no deductible. There is no coinsurance. You pay a flat dollar copay and you're done. Okay. The reason I bring that up is this last number here. Cosmetically, this is the number that gives most people heartburn. But I will tell you that this number here is the one that is unlikely to apply to almost anybody. The reason is that an annual out-of-pocket maximum, that is going to be what limits both your deductible, your coinsurance, and all of your copays. So if we kind of work through the math here a bit, if your annual out-of-pocket maximum is $6,350, but I've already told you that your deductible is $100 and your coinsurance max is $750, those two things add up to $850. The remaining amounts of the $6,350 has to be made up in copays. It would be very, very difficult to account for, what's the math there, about $5,700, $5,600 in copays. It would, again, it would be very difficult to pay $5,600 in $20 increments, or, and that actually includes your prescription drug copays as well. Just very, very unlikely that you can incur or have that many medical services over the course of a year in order to reach that out of pocket. The other thing to note is a lot of you right now don't have a limit, don't have an out of pocket limit. So you have an uncapped liability. So you could actually keep paying and continue to keep paying without any type of limits right now. So while it looks like a scary number, for some of you, that is actually a protection you don't have right now. Now, for some of you, you'll be going to the second plan. On the medical side, it is identical to the plan that we just looked at. There's no difference. The only difference is what you would pay for prescriptions. So in the first plan, this plan has $2 copays for generics and $5 for brands. In the second plan, you're going to have $5 generic copay, 20 for preferred brands, and 40 for non-preferred brands. Okay. That is the only difference between these first two plans. The last plan is for those of you that have benefits that are more closely aligned with the benefits that active employees have. This plan should look awfully familiar. This plan has a $250 deductible per person up to a $500 max. The coinsurance max is $750 per person, $1,500 for a family. And then the annual out-of-pocket max for medical is $3,000 per person and $6,000 for family. Okay. There is a separate out-of-pocket maximum that's specific just to prescription drugs. And that's $3,600 per person and $7,200 for a family. Okay. Again, these out-of-pocket maximums are very unlikely to apply. Otherwise, this plan has a 20% coinsurance, and $20 office visit copays, $150 copay for emergency rooms, $20 copay for urgent care and Cairo. Okay, so the plan in general works very similar to the first two plans. It's just the out-of-pocket or the deductibles and coinsurance are a little bit higher than the other two. But again, this plan right here is going to be very similar to the plan that that active employees have. All right, so I'm going to switch gears here. That kind of takes us to the end of the first part of the presentation. So I am going to switch gears to the Medicare portion. So just give me a sec here. All right. Andrea Walton, can you give me a thumbs up if you can see my screen? Awesome. All right. Thank you. Thank you, Andrea. All right. So we're going to switch gears now to the Medicare retirees. I think what you're going to find is that this program is a little bit less complex than the one that we just went through. So we're going to go through that now. Very similar to what we did before. We'll go through kind of current state, go through a summary, who the players are, and then we'll talk about plan design. So for those of you that are Medicare primary or Medicare eligible right now, you are likely getting benefits in a number of different ways. The first one, you might be receiving benefits through a HAP plan, so a PPO or an HMO. You might be getting your medical benefits through a Medicare Advantage plan with Health Alliance plan. So there's, I think there's only a couple handful of people that might have that benefit right now. And then some of you are receiving your benefits. Frankly, it's just a supplemental program through Blue Cross Blue Shield of Michigan. And everybody except those couple handful of people that have the Health Alliance Plan, Medicare Advantage plan, the rest of you are getting your prescription drugs through Express Scripts or Benistar, and that's being provided to you through what's called an employer group waiver program. And what that means is that the county is providing you with your Medicare Part D. You can always remember Medicare Part D, the D stands for drugs. So what are things going to look like on January 1st? Everybody, regardless of the arrangement that you have right now, you are going to be receiving your medical insurance through an Aetna Medicare Advantage plan. This Aetna Medicare Advantage plan includes a passive network. And what a passive network means is that there is no differentiation between your benefits if you use an in-network doc or an out-of-network doc. So the other way to think about that is really we're just piggybacking on the Medicare network. So as long as a doctor or a hospital accepts payment from Medicare, it is highly likely that they will accept your Aetna Medicare Advantage card. So again, I will restate that. If the provider accepts Medicare, it's highly likely that they will accept your Aetna Medicare Advantage card. We have a number of different organizations that my team works with that has Aetna Medicare Advantage plans. We very, very rarely run into an issue where a doc or a hospital won't take the card. And a lot of times when we do run into problems, we just have to talk to the right person at the hospital or in the billing department, because it's just an issue of somebody in the billing department isn't familiar with what a Medicare Advantage plan is. Okay. That's becoming less frequent because Medicare Advantage plans are gaining popularity. The enrollment in Medicare Advantage plans has been increasing at a pretty nice clip year after year. Also, just like the pre-Medicare folks, we're trying to keep the plan design changes to be minimal. Okay. There are plan design changes. There are going to be situations where you're going to pay a little bit more than you're paying right now, but we try to limit those changes. The other thing is that we are retaining and maintaining the relationship with Express Scripts. So even though you're getting your medical through a different carrier on January 1, you will not be getting your prescription drugs through a different carrier. Now, ID cards. Okay. Moving forward, on January 1, not before January 1, but on January 1, what I'd like you to do is, if you're accustomed to carrying your Medicare card around, I'd like you to put that Medicare card away in a safe spot where you're going to remember where it's at, okay? Because you will only need to carry your Aetna Medicare Advantage card with you going forward for medical services. You will no longer need to present your Medicare card when you're at the doctor, when you're at the hospital. You will only need your Aetna Medicare Advantage card. The reason for that is your Medicare coverage is actually integrated into your Aetna Medicare Advantage plan. Okay, so there's no need, and in fact, it will just cause confusion if you try and present both cards at the doctor. So only carry the Medicare Advantage, the Aetna Medicare Advantage card. You will also need to continue to carry your prescription card. That Express Scripts card is the card that you'll use and you'll present at the pharmacies to fill scripts. The other thing too is, like I mentioned to the pre-Medicare folks, the prescription drug world is always changing. So that also means that the list of covered medications change and things like that. And that works for us and against us. It works for us when new medications are rolled out and introduced to the market. Sometimes it works against us when generics are rolled out and we can't get the brands anymore. Okay, but that's constantly updated, and the industry is constantly changing. So just be aware of that. All right, now I mentioned before about the network and the fact that as long as a doc accepts Medicare, you should be okay. But if you need that reassurance, you can look on the website. The other thing you can do is just call your doc. If you're really concerned about it, tell them you're getting an employer-based Medicare Advantage plan through Aetna and ask them if they'll take it. And if they say no, you can get back in touch with us, but I would say 99% of the time, if they're participating in and accepting your plan right now, they're gonna accept the Aetna Medicare Advantage plan. And the reason I say that is because if you're going to them right now, most of the money that they're getting is actually coming from Medicare. It's not coming from Blue Cross Blue Shield or the county. It's coming directly from Medicare. So if they're accepting those Medicare payments right now, they're likely going to continue to accept the Medicare payments with Aetna. So plan designs, just like I mentioned before, we try to keep the plan design changes minimal. Like I said before, this is a passive PPO plan, so you shouldn't run into network issues. Also, you're going to be put into one of three plans, just like the pre-Medicare folks. There's going to be three plans, and the plan designs are going to look pretty darn close. They don't work the same because Medicare is slightly different. Medicare is a different animal than when you don't have Medicare. But just like the pre-Medicare folks, there's going to be one plan that has prescription drug copays that has $2 generic copays, $5 copays for any type of brand medication. And there will be two different plans that have $5 copays for generics, 20 for preferred brands, and 40 for non-preferred brands. And we'll talk a little bit more in detail about the plan designs in a bit. All right, I'm going to live up to my word. I promised you I was going to repeat this, so I am going to repeat it. In the event that it's not just you that you're covering, that you have a spouse that you're covering, or you have another family member that you're covering, any covered family member that is not on Medicare will get the pre-Medicare benefits that we talked about in the first half of this presentation. Those that are on Medicare will get the Medicare Advantage plan. So if you're questioning, well, does that mean, I'm not Medicare yet, but my spouse is? Your spouse is going to have a different benefit plan than you. Your spouse will have the Medicare Advantage plan, and you will have the pre-Medicare plan. By the way, behind the scenes, that's how it's working right now. Once you're on Medicare, as a retiree, Medicare becomes your primary insurance. All right, so plan designs. Okay. First thing you will notice here, we're not showing in and out of network benefits. You've got three different plans, so three columns here, three major columns. We're not showing in and out of network benefits. That is because there are no in and out of network benefits. There is only one level of benefits, and it doesn't matter if you're in network or out of network. So first things first, the deductible is $100. That's $100 per person. So if you get mapped to this plan, your deductible is $100. After that, you will pay either co-pays or co-insurance. Okay, so slightly different to the pre-Medicare plans. You need to pay this $100 deductible before the plan pays anything. Okay, other than preventive care. The plan will pay preventive care first dollar without having to satisfy a deductible. So you will be responsible for the first $100, and that's $100 per person. Okay, so if there's two of you that are covered, each of you have a $100 deductible, and you have an annual out-of-pocket max for your medical services of $1,100 per person. That means doesn't matter what type of situation you're in. If you have a catastrophic event, doesn't matter if it's an inpatient event, if you have a very expensive outpatient procedure or multiple outpatient procedures, in no year will you be responsible for more than $1,100 of out-of-pocket costs associated with your plan. In this plan, this is the plan that has $5 copays for generic medications, 20 for brand, a preferred brand, 40 for non-preferred brand. Okay. So these prescriptions are the only thing that doesn't count against the 1,100. The other thing you'll see is that you've got flat dollar copays for office visits. And the coinsurance, again, is 10% in this plan. The way coinsurance works is that you pay 10% of the allowed amount. Okay. So let's say that you go to have a diagnostic test. Again, and let's say you've satisfied your deductible for the year, and that diagnostic test is $50. Okay, and that's the amount that's approved by Medicare is $50. You pay 10% of that for $5. Okay. If that test was $800, you would pay 10%, and that's $80. That $80 then applies to this $1,100. Okay, so this $1,100 becomes $80 less what you have left to satisfy. Okay, but again, this number right here is what protects your financial position for the entire year. The next plan is identical to the first plan that we talked about. The only difference is the drug copays. In this case, those of you in this plan will have $2 copays for your generics and $5 for your brands. And the very last plan, again, this plan is going to be for those of you that have benefits that are meant to mimic or replicate the active benefits. So you'll see, again, you've got a $250 deductible. The annual out-of-pocket maximum, again, is $1,100. You've got the same flat dollar copay of $20 for office visits and the like. However, in this plan, the coinsurance, just like the pre-Medicare folks, it's 20% instead of the 10%. Okay? But otherwise, these three plans all cover the same things. So, you know, if you have this plan and your deductible's higher and your coinsurance is a little bit higher, doesn't mean that you can't get the same services that are provided in the first two plans. All three of these plans cover the same thing. Also, what you'll notice, some of you don't have hearing care right now. Okay, so hearing care was a benefit that was, it wasn't universal. Not every retiree has it right now. Everybody will have it moving forward, and you will also get a you'll get a hearing aid an allowance effectively. Every 36 months, you get $2,000 to use towards a hearing aid if you need it. So one of the other common questions that we've been getting is, you know, is there any type of gym membership that's included in this program? The answer is no, but Aetna does have discount programs. So while the actual full membership isn't included, they do have programs where you can get discounted memberships. That is if we're ever able to go back to the gym without, you know, face mask or six feet in between all of us on the treadmills. So, but yeah, so, and there are other benefits like that in the Medicare Advantage. It would take us an exorbitant amount of time to go through all of those. My recommendation is, as you get the materials in the mail and you're interested in, get yourself onto the website or call up the Aetna folks and ask them about the extra services that come along with your Medicare Advantage plan. And with that takes us to the end of the formal presentation here. I was 1 minute over my plan of an hour, which leaves us about 59 minutes to answer questions from the audience. Like Josh said, in the event that you've dialed in and you're not doing the screen sharing or the Zoom, if you press *9 *9 on your phone, that will raise your hand so we know to call on you. If you're using the Zoom feature, you should see a contacts button in the Zoom window. If you click that, kind of a white side menu will appear on the right-hand side of your screen. And there should be a button that says raise hand. That will do the same thing. That way Josh will know to call on you so we can answer your question.
Thanks, Jonathan.
Yep.
And if you'll stop sharing that screen, then that white participants box will show up for everybody over on the side.
Yep.
Just a reminder, everybody, that those presentations that Jonathan went through, they will be on our website, as well as video from today's meeting. So, as I said at the beginning, if you have any questions that you maybe think of after we're done here, feel free to reach out. I did put my contact information in the chat, and I'll give it again before we are done today. So it looks like our first caller is the 620-5398. You are muted, so *6 will unmute yourself. Are you out there? 620-5398.
Can you hear me?
We can, yep.
Okay. My question, I'm an actor 65er, so I'm on Medicare at this moment. And in the past, I have found that Medicare does not cover some tests, but my Blue Cross comprehensive major medical almost 100% would cover it. Is that the kind of thing that Aetna is going to do? Will they do the same thing that Blue Cross has done in the past?
There are enhanced services that are covered by the Medicare Advantage plan. Those things, it really depends on the service that you're receiving. But the Aetna Medicare Advantage plan does cover more than just basic Medicare services.
Okay. Okay. Thank you.
Mm-hmm.
Thank you. Looks like our next person is Emil Joseph. Are you out there? You'll need to unmute yourself.
Yes,
there you go.
I have two questions.
Perfect. Go ahead.
I received a comparison chart, and under the skilled nursing, it said that it references a benefit period. Can you explain what a benefit period is?
Yeah, the benefit period is a calendar year. Okay.
Okay. My second question is on the information that was provided to me previously. It states that in regards to prescriptions, that the copay increases $5 when using out-of-network pharmacy. Is that only in regards to the $2 item, or do the $5 become $10?
Yeah, the $5 would become $10 if you're using an out-of-network pharmacy. Correct.
And you can ascertain the whether or not they're in-network or out-of-network through the Aetna website?
You'd actually want to use the Express Scripts website.
Okay.
You could also call there should be a phone number on your Express Scripts card that you should be able to call and ask them if you need help determining whether that pharmacy is in network.
Thank you.
Mm-hmm.
Thank you. Looks like our next person is Vicki Walker. Vicki?
Okay. Hi, I have a question. You started out, I guess all the programs being offered are PPO, correct?
Correct.
Hey, I have no idea what a PPO is. So how does a PPO function different from the insurance I'm used to, my Master Medical through Blue Cross?
Yeah, so the PPO, really what it means is that there's a network of doctors and hospitals. So Vicki, are you pre-Medicare or Medicare?
Pre-Medicare.
Pre-Medicare. Okay. So what that means is that there is a network of doctors and hospitals, and that your benefits differ whether or not you're in network or you're out of network. Okay. Right now, your comprehensive major medical with Blue Cross, there's no difference between your in and out of network. The difference is that if you were to use a provider that doesn't accept Blue Cross's reimbursement level, the doctor can send you a bill for the balance versus what Blue Cross doesn't pay. In a PPO, if you go see an in-network provider, that provider is prohibited from sending you a balance. Okay, so if the provider builds $150, but they've agreed to accept 75, then they have to accept the 75, and they can't send you a balance bill for the difference.
Okay.
That's what a PPO is.
Okay, so I've heard of referrals are referrals involved in this PPO in any way?
No, they're
Like
not.
whether
There's no referral process whatsoever, and that really that's across the board. So for everybody else on the phone, there are no referrals. You can self-refer to specialists. You don't need to go to your primary care doc to get a referral to a specialist at all.
Okay, thank you.
You're welcome. Thanks for the question. Looks like our next caller is 231-373-7968. *6 will unmute you so you can ask your question.
Hi, my name is Peggy, and I am a retiree from Genesee County.
Hey, Peggy.
And I was curious, the plan that I retired under is where I wouldn't have to pay anything for a premium. And I understand right now there is no premiums to anyone, but in the future, if the county does have to switch to charging a premium for the employees, would I be charged?
So I can speak to that. There's been zero discussion by board members about charging premiums to anybody that currently does not have a premium. So for those folks that are in a plan that do not pay a premium, or they're retired under a plan that does not pay a premium, there's been zero discussion at the board level about, a year down the road or 2 years down the road of charging a premium for that plan. The only discussion around premium has been that cohort of folks that do not have, or that pay a premium now, reducing that to zero for this upcoming year.
Okay. And I had one more question.
Sure, go ahead.
As far as the specialty prescription, if you're currently on one of those and the doctor, sometimes they have to renew your prescription, can the new insurance not allow that?
No. So because we're not changing the prescription drug vendor, there won't be any loss of continuity there. Now, like I said, over the course of time, the pharmaceutical industry changes, and sometimes those specialty medications, there are new, better specialty medications that your doc might want you to take. So I won't say that, never say never, but there's no loss of continuity. So you're not going to have to jump through any hoops to get, to continue receiving the medication that you're receiving. Now, what you may find is that with this new program, if you're taking one of those specialty medications and you're pre-Medicare, that drug may be dispensed through a different channel, but you're going to be able to get that medication at no cost to you. So you might have to use a different pharmacy to get that medication, but you'll still be able to get it.
Okay. Well, will my physician have to go through the new pharmacy, or will that be an automatic switch where they'll be contacted to know?
We'll be sending out materials to the people impacted. So your doc, you may have to call your doc and have them send a new script to the pharmacy, but that would be the extent of it.
Okay. And then my last question is, if you do go to, I'm pre-Medicare, if you go to a doctor that's in network, and I think you answered it already, but I wanted to make sure that doctor will accept whatever Aetna pays, and I won't have to pay any higher things if they're in network. Is that correct?
You got it.
Okay. All righty. Thank you so much for your time.
Mm-hmm.
Yep. Thank you for your questions. Looks like our next caller is 240-3230-24. *6 will unmute you. 320-3024.
Hi.
Hello.
Hi. Okay. Please be patient. I have several questions. I listened in last night and then wanted to gather my thoughts and take a look on the website. And I'll start out with today and last night. You guys mentioned that most of the hospitals in Michigan were covered, but I'm no longer in the state of Michigan again. And I went to the Aetna website, but I wasn't finding any doctors or hospitals or anything where I currently live. So I've got some big concerns there. Can anybody address that?
Sure, Jonathan?
Yeah, if we can get your address, we can help you search for those doctors and hospitals. But it might be an issue of a setting is wrong or something on the search, but you shouldn't have issues finding docs and hospitals pretty much anywhere in the country. I mean, if you're living in a very, very remote area where you have to travel for healthcare in general, that might be an issue. But if you're living in any major metropolitan or suburban area, you should have both hospitals and doctors in your area.
Okay, the answers to both of those are no. I'm not in a rural area. So last night it just kept coming up the Medicare plan. I am in the pre-Medicare program or I will be placed in one of those. I'm thinking the Plan B, the mapping for Plan B.
Sure, if you just get your information, if you email it to me, I can get with Jonathan and we can find that information for you.
Is this Josh Freeman?
That's Josh Freeman.
Okay. Second question. Are we going to have to, how will the claims be handled? Is that something we're going to have to submit for payment or anything like that?
No. The only time that you would ever have to submit a claim for payment is if you went to an out-of-network doctor and they refused to send a claim for payment. Otherwise, it's going to work exactly like it does right now. The doctor's office will submit the claim to the insurance, and Meritain will process that claim according. They will make sure the doc gets paid, and then if there's some amount that you owe, you may get an invoice in the mail from the doc.
Okay, thanks for your patience, but I got more. When can we expect more information for the pre-Medicare side of the changes?
We'll be doing.
There's going to be more stuff coming in the mail, right?
Yeah, there'll be stuff coming in the mail. We'll also be doing additional sessions, kind of like this, but with the folks from Meritain. And so there'll be more detail and more information coming in future sessions.
Okay, and just a couple more. Like when I scrolled down and compared what I used to have with my Blue Cross Blue Shield, this is just a hypothetical situation, okay? I go in every year, get my physical. This will be my last physical under my old plan. But, he does comprehensive blood work, CBC, and all that kind of stuff. Now, when we go to the new plan, the preventative health says it's covered 0 all the way across the board. So is that CBC and the lipid profile and the UA, is that included, or is that going to fall under that 10% coinsurance?
So the preventive care, the coverage is going to follow the ACA guidelines. So anything that's defined as preventive care by the Affordable Care Act will be covered at 100%. Anything that isn't defined as preventive care would be subject to the out-of-pocket costs.
Okay, and the biggest thing, go ahead.
I was going to say, a lot of times that also has to do with how the doc's office bills it. So sometimes you're charged for that stuff and it's not correct because they don't bill it as a preventive visit. They bill it as diagnostic. So sometimes you just have to be looking out for it and then ask the question. Like if you don't think you should have to pay for something, that's when you'd want to call Quantum and ask for help.
Okay, and It just says colorectal exams. Now, there's a whole lot. There are a lot of different tests you can do
Mhm.
for cancer screening, but the gold standard has always been the colonoscopy. So, is that changing under the Maritime pre-Medicare program?
Not at all. Colonoscopies are actually are one of the items that falls under preventive care as defined by the Affordable Care Act. So
Uh-huh.
that can't change. It legally has to be treated covered that way.
Okay, so you've asked a bunch of questions. We've got some other people in line. If you could just raise your hand
Thank
again,
you.
and then we'll circle back to you if you have another question. I just want to make sure we get as many people as we can.
I understand.
next-
Thank you so much.
Not a problem. Thanks for being on the line. Our next caller, 869-1767. 869-1767. I see you're unmuted. Go ahead. Are you out there? Hello, caller. No caller. We're moving
Hello?
on. There you are.
There I am.
Come on.
Okay, I have a couple questions. I think you covered it with the fourth caller, but I heard you say something about those that are paying monthly premiums out of our pension.
Yes.
So did the commissioners decide that those of us that are paying monthly premiums are not going to be paying those?
Yes, they decided that in the upcoming calendar year, so starting January 1 with that pension payment, you will not have a deduction for health insurance. There will be no deduction for your premium. They also decided that they will reevaluate that on a yearly basis during the budget process. So through the next calendar year, 2021, there'll be no deduction for premiums.
Okay, so then if it does go up later on down the road, is it going to be the same as what I was paying when I retired?
So that's part of the issue that we are facing as a county, right? We've got like 30-some different plans and like, I don't know, 27 million different contracts that all say something different. So
Right.
whatever, if you were paying a static rate that did not change from year to year, and they decide to reinstate the premium after the next budget discussion, then you would continue to pay that static rate. But
Okay.
I mean,
I've always
so without knowing exactly your contract language, it's hard for me to tell you,
Well,
I don't know, do you pay a
contract language
static, do you
says-
pay what actives pay, that sort of thing?
No, mine says it is what I had when I retired, so mine's the static rate.
Okay.
So then if it gets reinstituted, I would be paying that same amount that I have been paying since I retired.
That is what this board has decided. As you know, I can't make you a promise that in 5 years a totally different board isn't going to do anything else, but that has been the discussions as we have gone through this process, is that if it becomes necessary due to budget reasons to reinstate the premiums, that it would be the same as prior.
Okay. And so
I'm trying not to like blow smoke up your rear end, right? I'm
Right.
trying to be honest with you about
Right.
what the
Thank you.
discussions have been.
Thank you. So in January then, my pension should see the increase from me not paying premiums.
That is correct.
Thank you. And my last question is, are dependents still covered until the age of 26 under this new plan?
Yes, that's consistent with the Affordable Care Act.
Okay, thank you.
You're welcome. Thanks for your questions. Jones? I see you.
She's muted.
You're muted, though. Bottom left corner of your screen.
Sorry
You
about
unmute her. There you go.
Okay. Most of the, I think, medical, I guess I've got to redigest everything, but one question, my first question is, what is the cost savings to Genesee County for implementing these new benefits?
So the estimated cost savings, if everything moves forward, is $6.8 million.
Okay. And also there was mention about, and I understand that, how many collective bargaining agreements that the county has had to deal with, but I would just like to state that those collective bargaining agreements were negotiated in good faith between labor and management.
For sure. Yep, I agree.
That's it for now.
Thank you.
Uh-huh.
Gladys?
Hello, I have
Hello.
2 questions. I'm one
Yes,
of those
ma'am.
odd people that I actually exceeded the copay and coinsurance due to a catastrophic injury a year ago. And with the change in this plan, because we're switching to a calendar benefit year instead of the June 1st to May 31st, does that mean I can exhaust my 60 permissible physical therapy sessions that I would have had to stretch out till the end of next May by December and then begin my new 60 under the new plan?
Will be one of the rare people that are going to benefit from, the calendar year aspect of this change. So it doesn't happen. It doesn't happen a lot, but you're going to be one of the few people that I think that this will definitely favor, because those will reset. They will reset.
Okay, because my physical therapy so far has cost $149,000 and I don't walk yet. And it's been since September of 19. So
Yeah.
that's why I'm asking. I never
Yes.
used my insurance for the 30 years I worked for the county. And
Are
an
you-
accidental injury killed me.
Yeah.
basically.
Are you pre-Medicare or
Medicare.
Medicare? Yeah. So it'll reset January 1st. And every year thereafter, it will reset on January 1st. Now, mind you, sometimes these limits with Medicare, when there's
Well,
medical
I'm
necessity.
pre-Medicare. I'm
Oh,
pre-Medicare.
you're pre-Medicare.
Yeah.
Okay, so I want to be clear. The limits that exist on these plans are, I don't want to say they're hard limits, because for most people they are, but when there is medical necessity, for certain people, I can't guarantee you may be one of them, this is a clinical thing. Sometimes those limits are expanded because
Blue
the
Cross-
care is medical, it's
Blue
medically
Cross
necessary.
did not extend anything. They wouldn't even let my doctor prescribe the medication that they wanted me on. They required that I get the $1.52 a month drug instead of the $1,500 a month drug.
Yeah. So I can't guarantee anything, but you will have different clinical folks looking at this. When the change occurs, you may find that the outcome is different. Okay.
And then I was in the new plan for retirement. So do I pay a premium starting January that's the same as what I'm paying now, or how does that work?
So for those paying premium right now, or for those that are,
But not coming out of a pension, it's out of pocket.
yeah, you would not. So you would not pay. Josh, is that accurate? If the person that's not collecting a pension but has to pay out of pocket for premium, their premium will also be given a holiday.
So like a
for
DC.
2021? Yeah.
So you were in like a 401 type situation, maybe? Yeah, that's true. No premiums.
So no premiums for anyone. Okay, thank you.
That's a
You're welcome.
one year holiday.
Yeah, well, that's enough to pay for half a session of
There you go. There
therapy.
you go.
Yeah. So, okay, but thank you.
You're welcome.
Thank you. Margaret, you're on deck. No, you're up to bat. Sorry.
Hi, I was going to ask a question. When my husband was in the hospital, he had to have on discharge 8 weeks to.
You muted yourself. Oh, just a minute. Star muted you.
Sorry. An accident.
Can you unmute her?
No, I can send her a message to unmute her. I'm very sorry.
Yeah, Margaret, can you unmute yourself on your screen?
Yes.
There you go. I
There I did.
apologize.
That's okay.
We fired her, so she's not here anymore.
Okay. I'm going to start all over again.
Yeah,
My
perfect.
husband was in the hospital and upon discharge was going to need IV infusions at home, twice a day for 8 weeks, antibiotics. The case manager at the hospital arranged everything to be done in the home and then for them to teach me how to do the IVs. We found out that Medicare decided to turn it down because it was not a pump IV, it was a bag IV. Now Blue Cross also is questioning if they are going to cover this. $19,000 worth of bills are going to be coming my way if Blue Cross doesn't cover it. Is in a situation like this, does Aetna also require case managers to handle anything that needs to be done in the home? And if
Yes.
so, to get an approval prior to having done this
Yes.
or
So,
not?
yeah, so their case managers will be required in appropriate situations like the one that you, the situation like you explained. Typically what's going to happen is those services are going to be pre-approved prior to the services actually being provided. It's the situation that you're dealing with is actually fairly uncommon because typically the insurance companies want to know, or I'm sorry, the medical providers want to know they're going to get paid before they provide the service. And so that's, it happens, it doesn't happen often, but I think what you're going to find with Aetna is that they're going to review those things and approve them before the care is actually delivered.
Okay, but in my situation now, because we were under the understanding that everything gets approved before he went home.
Yep.
And unfortunately, he just died 2 weeks ago. Am I going to be stuck with this $19,000 bill, or do you have a suggestion for me?
Yeah. So, so my suggestion to you would be if you get the $19,000 bill, because again, you're on Medicare. And your husband was on Medicare as well. So there's actually built-in protections in Medicare for things like this. But in the event that you are sent the bill, my recommendation would be that you should file an appeal. You have an appeals right, and you should definitely file an appeal. I can't guarantee an outcome, but based on what you've told me, it sounds like you have a very good case to appeal that to not to have to pay it. Okay.
Thank you.
You're welcome.
Thank you, Margaret. I'm sorry to hear that. Next caller, 231. We got a repeat caller. 231-373-7968. I think that's a repeat.
Thanks
Welcome.
so much for taking my, I thought of one last thing.
Sure.
When I call a doctor to find out if they accept the new insurance, which I'm sure they will, do I say I have Aetna or do I say I have Maritime to ask that question?
That's a fantastic question. So I'm assuming you're pre-Medicare.
That's correct.
If you're pre-Medicare, if you call your doctor, you should ask them if they participate with the Aetna PPO network. And if they ask you which one, you're going to say the Choice POS2.
Okay, so I do use the word Aetna.
Yes,
Okay.
but you're going to want to use the word participate. Okay, that's the key word. Okay.
Participate. I'm writing it down as we speak. Alrighty, thank you so much. I appreciate you taking my second call.
No
Yep,
problem.
not a problem. Thanks. Emil Joseph?
I apologize. I have two additional questions. One.
That's okay.
when do you expect the new cards to be sent out?
New cards are likely going to, the new cards should come out in December. We don't want to send them out too early because we don't want anybody to lose them. And if you don't have to use the cards, you're not going to be able to use them until January 1st. So we don't want to send them out too early.
Okay, second question. You had mentioned, I believe it was quantum for basically a patient advocate if it was pre-Medicare.
Mm-hmm.
Is there a patient advocate for Medicare?
Any type of service that you would need associated with your medical plan, you should contact Aetna. They're they're going to have specialized support services for the Medicare Advantage population, and that's who your contact should be.
Okay, thank you.
Thank you. We did get a couple of email questions from folks that are on, and I'm not sure why they didn't ask, but that's okay. Go ahead, Marie.
Well, yeah, I have an email from Diane Conley. I think that you're on the line, but you asked me to read this for you, so I don't know if you want me to, but I'm just going to, just to avoid some confusion. But she had said in question, I know of no one who has Aetna health insurance in Genesee County or surrounding areas. Is Aetna new as a health insurance carrier in our area? If not, how long have they been here? And provide some major employers who use them. If they are new, I'm concerned of how Aetna will perform as our new carrier. Who will support us if we have issues in getting care from them? And she's concerned that we're switching during a pandemic. So.
Yeah, so I understand I can understand all of the broad concern that's expressed there. Specifically, Aetna is not new. Aetna is one of the 4 largest insurance companies in the country, right along with United Healthcare, Cigna, and Blue Cross. I can tell you there are other employers in Genesee County that use Aetna. And specifically, if we're talking about the pre-Medicare solution, the Aetna network, I can tell you one of the major employers in town that uses them is Flint Moran. So we have a Flint office and have employees in Flint, and our employees all use the Aetna network. So that's one, larger employer that I know of off the top of my head. But there are other organizations. And employers in Michigan, absolutely, that use Aetna. If you've got questions or concerns, or you're having trouble with coverage, again, if you're pre-Medicare, your first point of contact should absolutely be Quantum. If it's something that you need to deal with, with HR, you're also able to contact HR. And in terms of changing during a pandemic, outside of making sure everything is covered, and that in the event that you're unfortunately hospitalized due to the virus or something like that, just making sure those things are covered. Changing during a pandemic shouldn't be a problem.
Okay, thank you. You got one other question,
Yeah,
Marie?
I have a question from Arthur Field, and he's wondering if Aetna plans cover in-home physical therapy. Just one might ask.
Yes, I should say it really depends. Again, if it's medically appropriate, it can. It also depends on if it's pre-Medicare or Medicare. Medicare is a little bit more particular about that type of thing. But again, if it's medically appropriate, it will be covered.
All right, thank you. Looks like 730-3566. *6 will unmute you.
Hi.
Hi.
My question is, I retired. I specifically retired so that I would retain my full employer-paid health care in 2012. So I don't pay any office. I have the HAP PPO, I believe, or HMO. I don't pay any office visits. I don't have any deductibles. I don't have any out-of-pocket expenses. I don't have any premium costs. I pay $5 for drugs.
Mm-hmm.
So under this new plan, and I'm pre-Medicare.
Okay.
So what I'm gathering for pre-Medicare, I will have $100 deductible
Mm-hmm.
per year,
Mm-hmm.
and that's used for office visits or anything.
The $100 deductible will only apply to major medical services in the pre-Medicare space. So if you have to go to the office for like a doctor's visit, it's just a flat copay. You don't have to pay your deductible.
Okay. What's a flat copay for a doctor visit?
$20.
$20. Okay.
Yep.
So,
And
and
just to be clear, one other thing to note: if you're in the HAP HMO right now, when we do this switch, you're no longer going to be in an HMO, so you will have a national network of physicians. So you'll actually have broader access to doctors and hospitals than you have right
yeah,
now.
that doesn't concern me. I'm in Genesee County. I plan to stay in Genesee County. So, I'm not looking to find doctors across the continent. And I get confused with, there's deductibles and there's copay and there's co-insurance. And I'm trying to figure out how much money I'm going to be losing. Currently, I pay zero out of my pocket. And I'm a cancer survivor. And I know as we get older, we usually end up with more medical conditions. So I'm going to be paying $100 deductible per year. And then the $750 is co-insurance per year?
Yeah, the $750 is the most that will pay in co-insurance a year. And the co-insurance is in 10% increments. So like if you go in for a service that applies to the co-insurance and it's $500, you're going to pay 10% of that, or $50. Until I hit $750. So
correct.
So if I have, let's say I have to have surgery again, cancer surgery and cancer treatment, say the whole bill wraps up to be $100,000. I'm only paying $750 that year.
You're paying $100 for the deductible, $750 for the coinsurance. So for those major medical, in total, you'd pay $850 for the year, for the entire year.
Okay. So I think I was getting cobbled up with that. Coinsurance maximum is $750, and we pay at a rate of 10%.
Correct.
Of the allowed payment.
Yes, you got it.
Okay. All right.
All right. Did you have another question?
Well, I don't understand what I'm looking for the $6,350 annual money. What is that?
Yeah, that's what's going to cap your copays. So like after you pay your deductible and after you pay your coinsurance, you're going to continue to pay copays for like office visits or your prescriptions. If you like I said,
that seems like an awful lot of money for unless I'm visiting the doctor once a week or getting.
It would actually, we've done the math. It would require you to be going to the office more than once a week.
Gotcha.
Yeah, it's just you're not going to. I don't want to say never, but it's very, very unlikely that you're ever going to hit that number.
Right. Okay, that makes sense now.
Yeah.
Okay. And if I am currently not in, is it cheaper to do Express Scripts than just go to Rite Aid?
So I'll let you guys in on a secret. Depending on the medication that you're using, like if it's a generic and the cost of the medication is below your copay, sometimes you're better off just paying cash as opposed to running it through your insurance. As crazy as it sounds, or if you've got
maybe that's what's happening with Rite Aid, because my coinsurance or my drug cost is usually $5 per prescription, and sometimes they'll say, okay, this is $2.65.
Yeah.
So they're giving me the better price.
Yeah. So sometimes,
Okay.
So the copay
so Jonathan, I can speak to that too. One of the prescriptions that I got, I went to Meijer to fill it because it was actually free for me when I went to Meijer.
Yep.
Yeah.
And a lot of times those scripts aren't actually run through the insurance because it's a program that Meijer has.
Right. So
yeah. Sometimes you're better off. There's also, if you've seen the commercials for GoodRx, sometimes you can get a better deal than on with using GoodRx than you can running it through insurance. So you just got to be a good consumer. If you want to take the time to do it, sometimes it works in your favor.
Mm-hmm.
All right. Thank you.
Thank you.
Questions? Looks like our next person is N. Turner. N. Turner. You'll need to unmute yourself. Are you out there, Turner? Turner, while you're working that out, we're going to go to Fernando. Fernando.
There we go.
There we go. Well, we got Turner is unmuted, so let's go to Turner first, and then we'll come back to Fernando. Go ahead, Turner. Goodbye, Turner. They were just kidding. Fernando, are you there?
Yes, this is Fernando's wife, who is also a retired county employee, pre-Medicare. And
Hello,
my
Fernando's wife.
Thank you. My question is directed more to you, Josh. I'm just confused. If people retired early to avoid an insurance premium, and the county is obviously having financial difficulties, why are they not deducting premiums from for the following year from people who were expecting to pay a premium?
Well, when they looked at what the potential changes were going to save the county, and what type of, as I said, there are like dozens of contracts out there, and for us to be able to track that has been literally a nightmare for our HR staff. We looked at what we're collecting in premiums versus what we were saving by making the change, and the board made the decision that they would set that amount aside and take that out of any potential savings.
It just seems to me that there could be an underlying clause they're going to take that away. I mean, if you can't afford to pay for retirees' benefits that you promised them benefits for life, and you are going to not take money from people who expected to pay their premium, that just doesn't make sense. I mean, take that money and put it towards your deficit that you have, following up with your promise to the retirees that retired and actually retired early because they wanted their benefits paid for. Why are you giving somebody a break that expected to have to pay that premium?
Sure. So it's about $336,000 this year on a $19 million bill. With those savings projected from this change, that's a decision that the board made.
Well, I mean, the last place you could put that money, you're going to have people that are going to have to pay, their year is going to change as far as them having to meet their co-pays. Put that money towards people who are only getting, 6 months of their deductibles made. I mean, some people are going to have to pay their deductible and 6 months later pay that. Why don't you put that money towards that? People retired in good faith under contracts negotiated by the employer and the employee. We all know it took sometimes a year and a half longer than it should have. A lot of time and energy spent on those contracts, and people retired early, took less money so that they wouldn't have to pay premiums. And now people that are expected to pay premiums went out knowing they are paying premiums because they weren't eligible to retire. You're going to give them a break, and then you're saying you can't afford to pay for the people that in good faith negotiated their contracts? That just does not make sense to me. There's got to be an underlying reason for that. Everybody's going to probably get hit the next year with the same premium, including the retirees that didn't have premiums.
Yeah, so all I can say is there's no conspiracy theories here. I gave you the explanation and what the discussion was with the board, and that's really as deep as it goes.
Okay, food for thought. Thank you for your answer.
Yep, thank you for your question. Connie? I see you there, Connie. You'll just lower left corner. There you go. Hey, Connie, what's your question?
Oh, I had a few, but I
Okay.
retired in 2005. I retired with 2 days' notice because it was very important to me to keep that contract language that I read extremely carefully. Did not like the change that was going to be voted on Monday. Got a presentation on Wednesday. Said I was retiring on Thursday and retired on Friday. I proceeded to pay COBRA for several months till my actual retirement kicked in because that contract language and the strength of it was so important to me. So that was 11 months of pay and 11 months of paying Cobra. And I have Blue Cross Blue Shield, Master Medical, love it. I love that it's 0% for when you're in the hospital. It's the hospital admissions, 0% on outpatient surgery. I like the prescription plans. I do see how, because when you're talking about how many office visits it would take to add up to the $6,350. I also see how it says it's integrated with medical, the prescriptions, and those $40 co-pays are also going to add up. No, I don't feel comfortable with the change at all. And I checked on the one prescription that I take. It was very hard to find the proper Express Scripts under Aetna. Express Scripts has so many formulas. I don't believe our Express Scripts formulas is going to stay exactly the same right now. And you keep portraying that it's going to be Express Scripts, but which Express Script? And my particular drug appeared to go from tier 2 to tier 3 and jumped right to a $40 copay.
Yep.
And that's only one prescription.
Sure. So Jonathan can probably get a little deeper in the weeds than I can, but I only tell you that for the county, the Express Scripts is not tied to the medical, right? So that's a separate contract that we have, and I do not believe that it's going to change your drug tier as we move forward. Now, Jonathan is the expert on that, and he can clarify, but I don't believe that changes, but I've been wrong once before, so.
It's Josh, this is one of those things that any changes, we're not doing it. The changes that happen in the drug industry cause the formularies to change. So things like going from a tier 2 to a tier 3, like Connie just mentioned, sometimes that's because that brand medication has been approved as a generic. And so now that there's a generic equivalent or available, and you can get that drug as a generic, the companies like Express Scripts move the brand up to a third tier to create a financial disincentive, or really more of a financial incentive, to use the generic instead of the brand, because the generic costs less. There's things like that happen throughout the year, every year. So Connie, that might impact you because of the medication that you're taking, where somebody else is taking a different medication, they're going to see no change whatsoever. So I don't want to say there aren't any changes, because you individually could be impacted because of the specific medications that you're taking.
But that's not as a result of the change by the county.
No, that's the industry changing. That's
right.
That's new drugs coming on the market. That's
independent of this change.
Yes.
Well, I actually was using a program that compares the two, and I was comparing Blue Cross Blue Shield. Well, I guess what I was using was called Coverage. It's an app. And I think it was because I need to know which Express Scripts we use. But you were saying the Express Scripts was coming in under Aetna, even though it's Express Scripts.
Yeah, for pre-Medicare folks.
Mine under Blue Cross Blue Shield stayed in tier 2. When it switched to the Aetna choice, it went to tier 3. It was not the drug company, it was Aetna.
Yeah, so Aetna does not control how prescriptions are covered under the county's plan. So the Express Scripts arrangement that the county has is not impacted by the relationship with Blue Cross or Aetna. That is a separate contract. It is managed separate from the medical insurance carriers. My guess is that the app that you're using is pulling in standard formularies, because Express Scripts actually sits behind Blue Cross Blue Shield in Michigan. Like if the county wasn't managing its own Express Scripts relationship and just using Blue Cross uses Express Scripts as well, but they use their own contract. The county has its own contract separate from Blue Cross and separate from Aetna with Express Scripts. Okay, so that app that you're using is likely leveraging or referring to contracts that aren't pertinent to your specific coverage through the county.
Okay, well, I do see Medicare books come out every year saying, here's your drugs and here's the tier they're in now, or here's a phone number you can call. What is our direction for that? And is that changing at all January 1st?
No, Connie, are you pre-Medicare or Medicare?
Pre-Medicare, so I'm going to be some Aetna.
Yeah. So you can call. You could call the number on your card. So you should have an Express Scripts card right now that has a customer service number. You can call them and ask questions about where your drugs are in terms of tiers, and where they might be as of January 1st.
Okay.
Do you have another question?
One more, just an example.
Sure.
You go in for a surgery or COVID and you end up with a $100,000, you end up with a huge hospital bill. We'll say $500,000. How would this plan pay that bill?
Yeah, so if you let's assume that you're in network and you get a $100,000 inpatient admission bill. Let's also assume that you haven't paid a cent for anything else through the year so far.
Right.
At that point in time, you would pay your $100 deductible. You would pay 10% of the remaining. So at that point, it would be 10% of
100,000 is 1,000.
Yeah, you pay $1,000, but at that point, your coinsurance maximum is going to kick in. So your coinsurance max would kick in at $750. So you would pay $100 of the deductible, $750 of coinsurance, and then you would be done for the year. So if you had another $100,000 surgery 3 months later, as long as it's in the same calendar year, you would pay nothing for that.
Okay, and then those special little bills they send you when you're in the hospital, this radiologist came in and that doctor came in, and then they end up saying, oh, but we were out of network, and they send you really fancy $300 bills. How does that work?
Yeah, so in the event that you are at an in-network facility,
hospital,
and they use an out-of-network radiologist or anesthesiologist, it's usually the IS. The in-network level of benefits will apply. Okay? They will apply. Here's the issue. There's that doc or that anesthesiologist or radiologist is still technically out of network. So if they will not accept the insurance payment as payment in full, they can still send you a bill for the balance. Okay, because they're not contractually obligated to accept the payment from the insurance company at that point.
And that's what I've seen happen. Somebody that's in a hospital and you're like under drugs. You can't tell that person, you're going to send me a $2,000 bill. I don't want you in my room. It doesn't happen that way.
Yeah, there's a lot of press on that topic. It's called surprise medical bills.
Yes.
Connie, honestly, if I had the answer, I'd make it happen.
I've also seen it happen with ambulances before. All of a sudden, somebody has a $1,900 ambulance bill.
I've seen a $400,000 air ambulance bill. So I've seen a lot. Those are problems in the healthcare industry that the county, we can't solve them. Those problems exist with Blue Cross. They exist with Health Alliance Plan. They will exist with Aetna as well. It's unavoidable with the way that the healthcare system works right now.
And the last question, Blue Cross Blue Shield was self-insured. The county literally was the insurer for Blue Cross Blue Shield. Is the county moving away from all self-insurance?
No, the county's actually moving all in on self-insurance. So
they are.
Yes. So this entire pre-Medicare solution is all self-insured. So the county is acting as its own insurance company for all pre-Medicare retirees.
For all pre-Medicare retirees.
Yes. The Medicare retirees are going to be, that's an insured arrangement.
Okay.
I should say
Okay.
the medical is insured. The prescriptions will still be self-insured.
Okay.
Okay.
Thank you.
Thank you. Looks like we got 412-4569. That'll be our last caller. *6 to unmute. There you go.
Hello, I'm a Medicare retiree, and I just have one question. Is our dental coverage and our vision coverage, do those remain the same, or are they included in this? Or
The dental and the vision will not be changing.
okay,
Yep, so that will stay exactly as is. No carrier change or anything like that.
okay, that's all I had to ask today. Thank you.
All right, thank you. Looks like that is the last question for today. Thanks, Jonathan, for the information. Thanks for everybody that was on the call today. Again, just a reminder, the presentations are on the county's website, as is a video of this, or a recording of this session. My phone number to my desk, if you have a pen and paper, is 810-762-7762. Email can be directed to that viba@co.genesee.mi.us. So happy to try to answer any questions. I am getting a few phone calls here over the last couple of days, so it is taking me a minute to get back to some folks, but I'll get back with you as soon as I can. Thank you.